So we're now in a position to put a few of these ideas together and look at our sepsis or severe sepsis screening tool. Now, any two of the following present and new to the patient. Temperature above 38 degrees centigrade would indicate pyrexia. Temperature below 36 degrees centigrade would represent cold sepsis. So that's a criteria if the patient's temperature is greater than 38 or less than 36. If the heart rate is above 90 beats per minute or more than about 20% above what the patient would normally expect. So there's a tachycardic response to sepsis, as we mentioned, because of the increased energy demand. Likewise with the respiratory rate, to get more carbon dioxide out and more oxygen in, if the respiratory rate is greater than 20 breaths per minute, that would be a sepsis criteria. If there's altered mental status, that is a sepsis criteria. If the white blood cell count indicates a leukocytosis of above 12,000 per cubic millimetre of blood, then that would indicate a sepsis, or if it's less than 4,000 cells per cubic millimetre of blood. Or if there's a hyperglycemia greater than 6.6 millimoles in a fasted patient in the absence of diabetes. Now, if the answer to that question is yes, the patient has signs and symptoms of sepsis. And then it's worth thinking about, is there any significant history? So, is the history suggestive of new infection? And the high-risk conditions are pneumonia, urinary tract infection, abdominal conditions such as abdominal pain, diarrhea, distension or post-laparotomy. Meningitis, of course, you can have the possibility of meningococcal septicemia. Cellulitis is a risk factor, as is septic arthritis, fasciitis or wound infection. Endocarditis, and any time there's indwelling catheters or intravenous lines or central lines is a risk. Now, if the patient has two of the relevant features, especially if there's a suggestive history, then we can consider that the patient in fact has sepsis. Are there any of the following present or new to the patient? So the physical signs, blood pressure less than 90, or a mean arterial blood pressure of less than 65 millimeters of mercury. New or increased oxygen requirement, in other words, if you have to turn the oxygen up to maintain the patient's saturations at above 90, that would be significant. And there's also relevant biochemical signs. So increased creatinine. This could indicate the development of an acute kidney injury or a lot of muscle catabolism, both indicating potentially severe sepsis. Because if there's acute kidney injury developing, that means there's an organ failure, so the sepsis is becoming severe. Or a urinary output of less than 0.5 mils per kilogram for 2 hours. So in an adult, we always want 0.5 mils per kilogram per hour. So that means in a 60 kilogram adult, we want at least 30 mils of urine. In children, we'll be looking for more than that. In children, we'll be looking for at least 1 mil, and in babies, we'll be looking for 2 mils per kilogram per hour. Another possible clinical feature is increased bilirubin. This can be caused by inflammation of red cells and apoptosis, but also in sepsis you can get a cholestasis. The bile doesn't move through the bile ducts properly, there's a cholestasis, meaning that bile can dam back up into the liver, and there can also be reduced function of the hepatocytes. If the platelets are used up, because the cytokines will cause inflammation of the endothelial surfaces in the blood vessels. This will release tissue factor, which will stimulate the development of thrombin, which will use up the platelets. And there can also be small fibrin clots in the vessels and aggregation. So the abnormalities of coagulation mean that the platelets are used up. So the platelets would become low, platelets less than 100, indicating a thrombocytopenia. Likewise with the coagulopathy. If the international normalised ratio is greater than 1.5, then that is a serious clinical indicator. And increase in lactate means that muscles and body tissues are hypoperfused. If they're hypoperfused, the metabolism will change from aerobic to anaerobic, and as a consequence, lactic acid will be produced, going into the blood as lactate. Now, if the answer to these questions is yes, then the patient has a severe sepsis, start severe sepsis pathway. If the answer is no, it can still be sepsis, so we still want to give oxygen, antibiotics, hourly national early warning score, fluid therapy, and we want to reassess the patient on a very regular basis. So this is the clinical outworking of some of the theory that we've just looked at. So again, early recognition of sepsis, absolutely vital. Suspect sepsis, save lives.